Imagine you have a medical emergency. You rush your child to the local clinic because they're violently ill.
Right.
You walk through those automatic doors, you see the sterile white walls, the medical posters, the staff in clinical uniforms, and your blood pressure drops just a fraction because you think, well, we are in the safety net.
Yeah, you assume you're safe.
Exactly. You think the entire purpose of this building and everyone in it is to heal the sick. But what if that assumption what if it's completely wrong?
And that's the terrifying part.
It is. What if the primary goal of that specific clinic isn't patient safety at all, but budget optimization? And what happens when a seasoned doctor realizes this cost-cutting experiment is actually mutilating patients, collects the hard clinical evidence to prove it, and brings it to the administration?
You'd think they would just call off the experiment immediately.
Right, any normal person would.
Yeah.
But in the case we are looking at today, the system decided the patients were the problem, the doctor was the problem.
It is a phenomenal and, frankly, a completely terrifying stack of sources we are pouring over today for this deep dive.
Oh, absolutely.
We are looking at a highly confidential paper trail.
Yeah.
I mean, internal NHS correspondence, medical tribunal records, deeply distressing photographic clinical evidence, communications from the British Medical Association, and excerpts from the whistleblower's own published works.
Specifically, Dr. Kadiyali Srivatsa's books, right? Tears of Happiness and Art of Self-Diagnosis.
Exactly. Those are our core sources.
And because we are diving directly into raw state documents today, really examining the actions of major government entities like the NHS and the UK Secretary of State, I want to be very clear right up front.
Yeah, that's an important caveat.
We are imparting exactly what is in these files. There's no political spin here, no left-wing or right-wing agendas. We are impartially reporting the contents of the documents.
Just conveying the events as they're recorded in the source material.
Right. We are simply tracing the anatomy of a medical whistleblowing case that escalated into this 8-year legal labyrinth against the state itself. So, if you are joining us on this deep dive, buckle up. We are going into the very dark mechanics of institutional self-preservation.
We really are. Our mission here is to dissect that friction between medical ethics and bureaucratic survival. Like when a large institution is forced to choose between admitting a catastrophic failure and destroying a single individual, how does it deploy its power?
Okay, let's unpack this. Because to understand why Dr. Srivatsa faced such an overwhelming retaliation campaign, we can't just start with a lawsuit.
No, you have to go back to the beginning.
Right, we have to start with the actual medical experiment that triggered his alarm bells in the first place. This all begins with a massive policy shift back in 2006.
Yeah, if we look at the historical and political context of 2006, the UK government, well, specifically the health secretary at the time, made a really controversial decision regarding how local healthcare is delivered.
And it wasn't popular with doctors.
Not at all. Against the explicit vocal warnings of the medical community, the government decided to remove what is known as the traditional demarcation barrier between doctors and nurses.
Let me stop you right there because I want to make sure we have the mechanics of this clear for the listener. A demarcation barrier isn't like a physical wall in the clinic.
No, it's a legal and professional boundary.
It's the strict, legally defined boundary of jurisdiction. Like who is legally allowed to make a diagnosis and prescribe a treatment?
Precisely. And for decades, those boundaries were rigidly enforced for a very good reason. I mean, becoming a general practitioner requires over a decade of intense study.
We're talking cellular biology, complex pharmacology, systemic pathology, all of it.
Exactly. And nurses, while absolutely vital and highly trained in patient care, monitoring, and specific clinical tasks, they just do not undergo that same decade-long diagnostic training. But in 2006, the Surrey Primary Care Trust, the PCT, which was a local administrative body for the NHS, decided to set up a pilot program. They established a quote-unquote nurse-led practice in Woking, which operated alongside 3 local walk-in clinics.
And let's be crystal clear about what nurse-led meant in this specific pilot, because we
Sure.
aren't talking about nurses doing triage or taking blood pressure or managing routine wound care.
No, the scope was vastly expanded.
The documents show that these nurses were suddenly permitted to consult registered patients, physically examine them, form a primary diagnosis, prescribe medications, and monitor those illnesses entirely without a doctor's supervision.
That phrase, without supervision, is the absolute pivot point of this entire disaster.
It's wild.
It is. This pilot was essentially a beta test. The underlying administrative goal was to see if the NHS could roll this model out nationwide, creating independent nurse-led practices that could act as the primary medical gateway for citizens across the entire country.
But wait, I'm going to play devil's advocate here for a second. If I wake up with a scratchy throat and a runny nose, do I really need a doctor who spent 12 years studying the intricacies of the human renal system to tell me to get some rest and take some ibuprofen?
I see where you're going with this.
Right. Like, isn't it just logical resource management to have a nurse handle the simple stuff so the doctors can focus on the complex, life-threatening cases? I can see the bureaucratic appeal of that.
It sounds incredibly logical on a spreadsheet, sure.
Yeah.
And what's fascinating here is that the motive wasn't pure malice, it was financial.
It always is.
Always. The sources point out repeatedly that maintaining a staff of highly specialized doctors is the largest line item in a clinic's budget. Nurses command significantly lower salaries.
So it was just cutting corners.
Dr. Srivatsa's notes explicitly identify this as a move to cut corners and save money, just cloaked in the buzzwords of innovation and expanding patient access. But your devil's advocate question hits on the exact flaw in their logic. Well, you assume your scratchy throat is simple. But in human biology, there is no such thing as a guaranteed simple symptom.
Right, because human beings aren't flowcharts.
Exactly.
Yeah.
The symptom of a minor self-resolving viral cold can be the exact same initial presentation as a lethal bacterial infection, an autoimmune flare-up, or even early-stage leukemia.
Oh, wow.
And this brings us to Dr. Srivatsa himself, who was working as a salaried GP in the very area where this experiment was taking place. He had nearly 2 decades of experience, heavily focused in pediatrics, and he had a very specific philosophy about what a doctor actually is.
And this is something I found so compelling in his writings. We have all been conditioned by medical dramas. You watch TV, and the doctor is the hero sprinting down the hallway with defibrillator paddles shouting, "Push 1 milligram of Epi, we're losing him."
Right, the classic Hollywood doctor trope.
We think a doctor's primary job is to snatch people back from the brink of death in an acute crisis.
But Dr. Srivatsa argues that this dramatic framing is essentially brainwashing. He states that the absolute first duty of a doctor, the entire reason they spend over a decade studying the interconnected systems of the human body, is not to perform heroic resuscitation.
Then what is it?
It is to make the correct diagnosis early so that the complications never happen in the first place.
Because if you make the correct diagnosis on day 1, you never need the dramatic hallway defibrillator scene on day 20.
Precisely. And making that early correct diagnosis requires an immense depth of knowledge regarding how drugs actually function within the body. Dr. Srivatsa highlights a terrifying reality about modern pharmacology that most patients just don't understand.
Yeah, this part blew my mind.
The general public assumes that when a medical professional hands you a pill, that pill is designed to cure you. But doctors know that with the exception of antibiotics, which are designed to actively seek out and kill the specific bacteria causing an infection, the vast majority of drugs do not cure anything.
They just mask the symptoms.
They are purely symptomatic treatments. I mean, anti-inflammatories reduce swelling. Antidepressants alter neurochemical uptake. Antivirals suppress replication, but often rely on your own immune system to do the actual clearing.
And steroids.
Steroids suppress the immune system to stop inflammation. They manage the pain, they reduce the discomfort, but they're not designed to eliminate the root cause of the illness.
I want to give an analogy here because this really clicked for me when I was reading his notes. Imagine you take your car into a shop because there is thick black smoke pouring out from under the hood.
Okay, I like where this is going.
You want a mechanic to do a deep diagnostic check, realize you have a blown head gasket, and replace the failing part. That is a cure. But instead of a mechanic, a salesperson comes out. They don't know how an engine works, but they have a checklist.
A protocol.
Right. The checklist says, if smoke is present, improve the air quality. So they paint over the rust on your hood and they hang a really strong pine-scented air freshener from your rearview mirror.
That's horrifying.
But you drive away feeling great, the car smells nice, the outside looks shiny, but the engine is still fundamentally broken, and because you've been given this false confidence, you are going to keep driving it until it explodes on the highway.
That is a phenomenal analogy, and it perfectly encapsulates what Dr. Srivatsa termed the false sense of security.
Yeah.
By making nurses the first and only port of contact, the Surrey PCT weaponized the trust that patients naturally place in the healthcare system. The patient walks in, sees the clinic, speaks to a professional in a medical uniform, and assumes that the person across from them has the deep diagnostic experience to identify the root cause of their suffering.
And it's crucial we emphasize that this isn't an attack on the nursing profession itself.
Not at all. I mean, what's fascinating here is that studies absolutely show that nurse-led interventions can be incredibly positive. They frequently result in high patient satisfaction and excellent outcomes.
But there's a catch.
A massive qualifier, yeah. Those positive outcomes only occur in specific, highly supported contexts. It works brilliantly when nurses are managing known chronic conditions they are specifically trained for, like running a diabetes management clinic, or when they are working collaboratively in a team with doctors.
Right.
It completely falls apart when nurses are forced to act as primary diagnosticians outside their jurisdiction, following rigid algorithmic checklists without fully understanding the underlying biological nuances.
Because when you only have a hammer, everything looks like a nail. Or in this case, when you only have a flowchart, every symptom gets forced into a predetermined box.
Exactly.
And this isn't just a theoretical debate about healthcare models. Dr. Srivatsa, as the salaried GP working nearby, began to meticulously review patient notes. He started seeing a terrifying pattern emerging from these walk-in clinics and the nurse-led practice.
The nurses were following their protocols, prescribing symptomatic relief, and entirely missing severe underlying conditions.
And this is where the deep dive gets incredibly heavy. It's one thing to discuss budgets and medical philosophy. It is another entirely to look at the hard clinical evidence Dr. Srivatsa compiled.
The case histories.
Yeah. He documented a series of harrowing case histories, complete with clinical notes and, in some cases, photographs, that demonstrate exactly what happens when diagnostic expertise is replaced by a protocol checklist.
We really need to walk through these cases because this is the undeniable evidence that triggered the entire war. We aren't going to just read a list. We need to look at the mechanics of these clinical failures.
Absolutely.
Let's start with the category of cases where symptomatic masking led to disaster. There's a case in his files of a patient presenting with a simple throat infection.
A routine presentation, you'd think.
Right, but the biology of a throat infection can vary wildly. Is it viral? Is it bacterial? If it's bacterial, what is the likely strain and what is the current local resistance pattern?
And the nurse didn't know that.
Because the nurse lacked the deep pharmacological training to understand bacterial resistance and proper dosing thresholds, the prescribed antibiotic dose was far too low.
So it didn't kill the bacteria, it basically just annoyed it.
It did worse than annoy it. By providing a sublethal dose, they inadvertently selected for the most resistant bacteria. The infection wasn't eradicated. It festered, mutated, and spread deeper into the tissue, resulting in a tonsillar abscess.
Oh, that sounds awful.
It's a severe, localized collection of pus that can block the airway. What should have been a minor inconvenience, cured by a proper 5-day course of antibiotics, became a severe, incredibly painful condition requiring surgical intervention and emergency care.
And then there was the case of the family diagnosed with eczema. This one blew my mind because of how basic the error was.
This case is a perfect example of the danger of visual checklists. A patient presents with red, itchy, irritated skin. Eczema is an autoimmune inflammatory skin condition. It is very common. So the nurse checks the itchy red skin box, diagnoses eczema, and prescribes a steroid cream.
But the patient didn't have eczema. They had scabies.
Yes, scabies is not an autoimmune issue. It is a parasitic infestation. Microscopic mites physically burrowing into the top layer of the human skin to live and lay eggs.
Oh my God. And what happens when you put a steroid cream on a parasitic infestation?
It is an absolute biological disaster. Steroids work by suppressing the local immune response to stop inflammation. The itching and redness of scabies is your immune system trying to fight off the mites.
So the cream just turned off their defenses.
By applying the steroid cream, the nurse effectively turned off the patient's local immune defenses. It acted like Miracle-Gro for the parasite. The mites were able to breed and spread unchecked, masking the symptoms while the infestation worsened exponentially.
And because it was masked, it spread.
Because it was misdiagnosed and the core cause wasn't treated, the infestation spread to the entire family. A doctor with proper diagnostic training would have recognized the specific physical burrow marks, the tiny thread-like lines in the skin, and prescribed a targeted, topical antiparasitic to kill the mites.
Instead, the family suffered immensely due to a mask protocol. Let's shift to another category of failure. What happens when you treat a symptom without ever asking why the symptom exists? This next case absolutely breaks my heart.
12-year-old girl.
Yeah. A 12-year-old girl comes into the clinic complaining of severe tiredness. The nurse looks at her, runs down the flow chart, and diagnoses her with simple anemia low iron.
A classic, devastating protocol-driven error. In the algorithm, tiredness equals anemia. The action item is to prescribe iron supplements. But tiredness is one of the most nonspecific symptoms in all of medicine.
It could be anything.
It can indicate a lack of sleep, a poor diet, mononucleosis, thyroid dysfunction, leukemia, or organ failure. Because the nurse stopped at the first, easiest, most common answer on the checklist, they never ran the complex differential diagnostics required to rule out the dangerous outliers.
They just gave her iron pills and sent her home.
And because she was taking the pills, the family had that false sense of security. They thought she was being treated. But the underlying issue was renal failure.
Her kidneys.
Her kidneys were slowly dying. Because the diagnosis was delayed by the superficial treatment, the damage became irreversible. By the time she was 14 years old, that young girl had to have her kidneys surgically removed.
That is just, it's a completely preventable organ loss if a doctor had been present to look past the surface symptom of tiredness.
Exactly.
Think about that for a second. If you are listening to this, think about the immense trust you place in a medical facility. How would you feel knowing that the person treating your exhausted child is just checking a box on a laminated sheet, completely unequipped to understand that her organs are shutting down?
It's chilling.
And the gross negligence only gets more extreme. There is a case in the documents regarding a dying woman. She is already on heavy chemotherapy and steroids for cancer. She comes into the walk-in clinic with a sore throat, and the clinical notes show she is treated with something transcribed as Banjul.
Which is an incredibly bizarre note. Banjul is the capital of the Gambia, not a medication.
Wait, really?
Yeah, it is highly likely this is a phonetic transcription error in the clinical records for something like Benylin, an over-the-counter cough syrup, or some other superficial throat lozenge or soothing agent. But regardless of what that specific word was meant to be, the medical action it represents is a profound failure of immunology.
Because a cancer patient isn't just a regular person with a sore throat.
Exactly. A patient on active chemotherapy and high-dose steroids has virtually no immune system. They are entirely immunocompromised. In an immunocompromised patient, a sore throat is not a cold. It is a red alert, sirens blaring emergency.
It could be deadly.
It could be the first sign of a systemic, opportunistic infection that could kill them in a matter of hours. You do not give a chemo patient a cough syrup or a throat lozenge and send them home. They require immediate aggressive blood cultures and broad-spectrum antibiotics to save their life. Offering a superficial soothing agent to someone in that condition is staggering negligence.
It shows a complete lack of understanding of the patient's holistic state. The flowchart says sore throat equals lozenges. It doesn't have a subroutine for patient has 0 white blood cells.
Right. The protocol's blind.
And speaking of a lack of basic medical process, we have to talk about the physical examinations, or rather, the lack of them. A 23-year-old woman comes in complaining of hirsutism.
Which is excessive male pattern hair growth on her face, chest, and legs.
Right, and she is wildly misdiagnosed. Why? Because the notes show the nurse examined her chest over her clothes.
In medicine, there is a fundamental rule. You cannot diagnose what you do not see. To perform a clinical examination for a dermatological or endocrinological complaint without actually looking at the skin is a failure of day one medical school training.
It's absurd.
Hirsutism is often a marker for complex hormonal imbalances like polycystic ovary syndrome or even adrenal tumors. You cannot assess the severity, the distribution, or the nature of the hair growth through a sweater. It is clinical theater, not medicine.
And the blind diagnoses continued. A patient presented with tummy pain and vomiting. The clinic diagnosed and treated her for gastritis inflammation of the stomach lining.
And what was the actual reality?
She was pregnant.
A basic pregnancy test is step 1, page 1, for any woman of childbearing age presenting with abdominal pain and vomiting. It's Diagnostic 101. To prescribe medication for gastritis without confirming pregnancy is dangerous, as many medications are teratogenic, meaning they can harm the developing fetus.
Here's another one regarding jurisdiction and overstepping boundaries. A child with a neurological condition was suffering from spasticity, severe muscle stiffness and involuntary spasms. Why? Because the nurses at the clinic unilaterally decided to stop the child's ongoing treatment.
Again, acting entirely outside of their depth. When you are dealing with complex neurological medications, you cannot simply stop them abruptly. There are severe physiological rebound effects. A doctor understands the pharmacology of tapering doses. A nurse following an administrative directive to reduce medication costs, or simply misunderstanding the ongoing treatment plan, caused a child immense physical pain.
We also have a 12-year-old girl who came into the clinic terrified because there was fresh blood in her panties. The nurses diagnosed her with a urinary tract infection and treated her blindly for it without ever performing a physical examination.
Which is dangerous on multiple cascading levels. First, diagnosing a UTI without an exam or a proper culture often leads to inappropriate antibiotic use. But far more importantly, a 12-year-old presenting with unexplained bleeding requires a delicate but thorough investigation.
You have to know where the blood is coming from.
You have to identify the actual source of the bleeding. Is it early onset menstruation? Is it a severe internal infection? Or, tragically, you have to rule out trauma and abuse. Handing out UTI pills and ignoring the physical reality of the child is a massive dereliction of duty.
And perhaps the most visually shocking case detailed in Dr. Srivatsa's clinical notes, a young child presenting with chronic vomiting. The nurses diagnosed a milk allergy. They treated this child for a milk allergy for 18 straight months.
18 months. Think about the timeline of that suffering.
The underlying condition, which was far more severe, was ignored for so long that the child developed profound facial deformities. The clinical notes describe the child as looking, and I quote, like a toad with bulging eyes.
It is grotesque. 18 months of incorrect treatment, 18 months of the parents trusting the clinic,
Right.
while a severe deformative physiological condition was allowed to progress completely unchecked.
And there are still more cases in the pile.
It doesn't stop. We see moles and a vascular disorder called Henoch-Schönlein purpura, or HSP, wildly misdiagnosed as meningitis, causing severe, unnecessary panic and trauma for the families. We see a patient with a neck rash treated for shingles, only for the underlying bacterial infection to progress into septicemia blood poisoning, which is frequently fatal.
It is an absolute avalanche of suffering.
If we connect this avalanche to the bigger picture, Dr. Srivatsa frames these specific case histories around the concept of medical ethics. He makes a very clear, defining distinction in his writings. He says we cannot view these as just innocent, inevitable mistakes.
Right, they aren't just oopsies.
When a system intentionally structures itself to place unqualified personnel in diagnostic roles purely to save money, the resulting harm ceases to be an accident. It becomes what he labels negligent care.
Yeah.
He goes even further, resurrecting a very heavy word, quackery. He defines quackery in the modern era as prescribing drugs without the fundamental medical knowledge required to understand their systemic effects and prevent complications.
And the ultimate tragedy here, the thing that really gets under your skin when you read the documents, is that these patients were entirely in the dark.
They had no idea.
They had no idea that their prolonged illnesses, their irreversible complications, their lost organs, or their child's facial deformities were the direct result of a substandard experimental NHS care model. They walked through those automatic doors, they trusted the system, and the system betrayed them to save a few pounds on the balance sheet.
They believed they were receiving the national standard of care. They weren't. They were unwitting subjects in an administrative cost reduction experiment.
So let's put ourselves in Dr. Srivatsa's shoes for a minute. He is sitting on this mountain of evidence. He has the clinical notes. He has the photographs. He sees the systemic failure causing undeniable physical harm to children and adults in his community.
A heavy burden.
Armed with this evidence, he did what any ethical doctor bound by the Hippocratic Oath would do. He blew the whistle. But the system's reaction was the exact opposite of what he expected.
He was, by his own admission in his later writings, incredibly naive about how large bureaucracies function. He operated under a fundamental assumption that the primary goal of the Surrey PCT, his employer, was patient safety.
A reasonable assumption.
Right. His logic was simple. If the administration doesn't know patients are being harmed, and I show them undeniable proof that patients are being harmed, they will thank me, halt the pilot program, and fix the problem.
Right. It's the if you see something, say something mentality. So in August 2006, he made what is legally known in the UK as a protected disclosure.
A formal whistleblower complaint.
Yeah, this is a formal official complaint that is supposed to be shielded by law against any form of retaliation. He posted on a secure forum called doctors.net, expressing his deep discomfort with the unsupervised nurse practitioners covering emergency out-of-hours calls. He explicitly stated that the practice was not safe. He also raised the issue with the PCT formally and in strict confidence.
And then he waited. He assumed the chairman of the Surrey Primary Care Trust would contact him, invite him to a board meeting, sit down, review the clinical cases, and look at the hard evidence he had meticulously gathered.
Instead, there was silence. Complete silence for 3 months.
And then
And then he received an email. The email cheerfully informed him that his highly confidential, legally protected complaint had been forwarded directly to the manager of the walk-in clinic and the pilot nurse-led practice.
This raises an incredibly important question about the nature of power. Why would a regulatory body do that? It is a catastrophic breach of protocol.
They just handed over his name.
The PCT essentially took the whistleblower's identity, along with his detailed complaints regarding specific clinical failures, and handed them directly to the very people committing those failures. They handed the target to the people he was accusing of negligent care.
It's like discovering a ring of corrupt police officers, taking your evidence to the chief of police, and the chief just prints out your complaint, highlights your home address and phone number, and pins it to the precinct bulletin board for the corrupt cops to see.
Exactly. Because we have to look at the psychology of the institution. How does a bureaucracy protect itself when faced with an existential threat?
By neutralizing the messenger.
Yes. The Surrey PCT administration quickly realized that acknowledging Dr. Srivatsa's evidence would mean admitting that their flagship cost-cutting experiment was a dangerous, negligent failure. It would open the trust up to massive public scandal and millions of pounds of medical malpractice liabilities. The easier, cheaper path was to eliminate the doctor raising the alarm.
And so begins the retaliation campaign. The documents contain a fascinating and deeply chilling statistical anomaly regarding complaints against Dr. Srivatsa. Let's look at his record. For his first 10 years of practice, from 1997 to 2007, he had a grand total of 2 complaints against him.
2 complaints over an entire decade.
Over an entire decade, seeing thousands of patients.
That is a remarkably clean record for a primary care physician, especially one dealing with the high stress of pediatrics and out-of-hours care.
But suddenly, in 2007, directly after his protected disclosure is leaked to the clinic staff, there are 4 complaints filed against him. By 2008, there is a staggering explosion. 12 complaints filed against him in a single year.
It is a manufactured avalanche. The internal documents show that a formal meeting was held on December 11, 2007. The attendees included the medical director, Dr. Graham Henderson, and Mrs. Frida Smithers.
Did they use this meeting to discuss patient safety?
Did they review the 14-year-old who lost a kidney or the child who looked like a toad? No. The entire focus of the meeting was initiating fresh disciplinary investigations against Dr. Srivatsa based on these sudden, highly suspicious complaints.
And what is wild is that by March 2009, the majority of these sudden complaints were quietly withdrawn. Why? Because they were entirely unsubstantiated. They were fabricated.
But the truth of the complaints didn't matter.
The damage was the point. The process is the punishment.
That is a classic textbook institutional suppression tactic. You overwhelm the whistleblower with defensive paperwork. You force them to spend all their time, their emotional energy, and their financial resources defending their own medical license and reputation, so they have absolutely no bandwidth left to pursue the original issue of patient safety.
Here's where it gets really interesting and, frankly, incredibly dark. The documents reveal the most vicious tactic used against him: the threat of sexual misconduct allegations.
This is the nuclear option in professional warfare.
The nurses and staff at the clinic, the very people whose errors he had exposed, began whispering that he acted inappropriately. Remember the 23-year-old woman with hirsutism?
The one who was misdiagnosed because the nurse examined her over her clothes.
That's the one. She suddenly filed a complaint claiming to be a medical student, alleging inappropriate behavior by Dr. Srivatsa.
Let me stop you to emphasize the gravity of this. In the medical profession, especially for a male doctor, an allegation of sexual misconduct is an immediate, catastrophic career ender.
It doesn't even need to be proven, does it?
No, it doesn't even need to be proven in a court of law. The mere whisper of it destroys your reputation in the local community, prompts immediate suspension from the medical register, and triggers devastating, highly public investigations. It is a bell that cannot be unrung.
Dr. Srivatsa realized exactly what they were setting up. He saw the trap being laid. He was so terrified of being framed for sexual abuse by the coordinated clinic staff that he outright refused to return to the surgery. He stayed home. He knew that if he walked through those automatic doors, he would be walking into an ambush that would end in his arrest.
And this brings us to the next, arguably more insidious phase of the institutional attack. With the doctor terrified to even enter his own clinic, the bureaucracy shifted from clinical complaints to full-scale administrative and psychological warfare.
We're talking about the weaponization of process and, incredibly, the weaponization of mental health.
Let's look at the timeline of the inquiry they launched against him. A standard internal inquiry of this administrative nature should have taken about 5 weeks to conclude.
5 weeks.
Instead, The PCT intentionally dragged it out for over a year, and it eventually metastasized into various overlapping disciplinary forms lasting 4 years. During this protracted torture, they introduced a deeply sinister tactic. They ordered Dr. Srivatsa to undergo a mandatory psychiatric evaluation.
Think about how degrading and gaslighting that is. You raise a scientifically backed, evidence-based alarm, complete with clinical notes and photographs showing that children are being harmed by medical errors, and your boss's response is, "You sound crazy. We need to have your head examined."
It is one of the oldest tactics of authoritarian structures, pathologizing dissent.
Yeah.
If the administration can label the whistleblower as mentally unstable, paranoid, or suffering from acute stress, they immediately invalidate all of his clinical evidence.
You transform a systemic institutional failure into a personal psychological breakdown of one employee.
Exactly. But the psychiatric evaluation backfired on the PCT in a very specific, documented way.
It totally backfired. The independent psychiatrist examined him, evaluated the situation, and concluded that yes, the clinic environment was incredibly toxic, and therefore returning to the surgery would be severely detrimental to Dr. Srivatsa's mental health.
Right.
The official medical advice from the psychiatrist was, do not send this man back into that hostile environment.
And how did the Director of Medical Services respond to this official independent medical recommendation?
Yeah.
By blatantly ignoring it. They forced him to return to the clinic. They issued a directive knowingly placing him back into the exact environment the psychiatrist warned against, which predictably restarted the entire cycle of fabricated complaints, hostility, and fear.
And while all this psychological pressure is being applied, the system is simultaneously breaking its own fundamental rules to dig up dirt on him. The documents show that other doctors within the trust were allowed to go through Dr. Srivatsa's confidential patient notes without his consent.
And crucially, without the patient's consent.
Right.
Which is a flagrant, legally actionable violation of what is known in the UK as the Caldecott Principles.
Wait, explain the Caldecott Principles real quick, for those who don't know.
Let me explain these, because they are the bedrock of medical privacy. The Caldecott Principles are strict, legally binding guidelines that govern exactly how, when, and why patient-identifiable information can be shared. You cannot just go fishing through private medical records looking for administrative ammunition against a colleague.
So they just broke the law to get him.
It requires strict justification, usually directly related to patient care. Breaking this principle is highly unethical.
It's a total double standard. The PCT is actively violating patient confidentiality and breaking national guidelines to destroy the man who is trying to save patient lives. And when the psychological pressure and the privacy violations weren't enough to make him quit, they moved to the final stage of institutional suppression: financial starvation.
If you want to break a whistleblower who refuses to yield on principle, you cut off their ability to feed their family.
Dr. Srivatsa, unable to safely work in his own clinic due to the hostile environment and the constant threat of false allegations, sought permission to work as a locum. For those who might not know, a locum is essentially a substitute doctor.
Right, covering shifts.
He just wanted to practice medicine at another surgery in a different town. While the dispute was being settled, he wanted to work.
But the PCT actively blocked him. They claimed his name was suddenly missing for the official performers list, which is the National Registry of Approved Doctors allowed to practice in the NHS.
And what was their excuse?
The reason given for this omission: a convenient computer error.
Right. A random computer error that just happened to exclusively target the one specific doctor who was challenging the state's clinical pilot program. How incredibly unlucky.
That error prevented him from earning a living anywhere in the National Health Service. And then, the final administrative blow was delivered. On December 27, 2009, his salary was officially suspended entirely.
Merry Christmas from the NHS.
He is now completely without income, entangled in a labyrinth of disciplinary hearings, and functionally blacklisted from practicing his profession.
Now, you might be wondering, where is his union in all this? In the UK, doctors rely heavily on the BMA, the British Medical Association, for legal and professional protection against exactly this kind of state overreach.
Yeah, the safety net for doctors.
Right. Dr. Srivatsa initiated formal grievance proceedings. He meticulously compiled a list of 99 specific points of wrongdoing, detailing the clinical errors, the retaliation, the Caldecott breaches, and the breach of protocol.
And the sources indicate a profound institutional betrayal here as well. The BMA is supposed to be the shield for the doctor, But his BMA representative, a woman named Tessa Margry, completely evaded discussing the 99 points of clinical and administrative wrongdoing.
She just ignored it.
Instead of fighting the core issue of patient safety and retaliation, she offered a placating, empty promise to simply find him a new job elsewhere. A job that, predictably, never materialized because he was still technically tied up in the PCT's disciplinary web.
I want to ask you, the listener, to stop and put yourself in his shoes for a moment. Feel the walls closing in. You are trapped. You have absolutely no income. Your professional union, the people you pay dues to for protection, has effectively abandoned you. The medical director is actively hunting for ways to destroy your career. The administration is violating patient privacy to frame you. And if you physically walk into your office to do your job, you face the very real threat of being falsely accused of sexual misconduct.
It's an impossible situation.
What do? Do you surrender?
When every internal mechanism designed for justice has been corrupted or turned against you, there's only one path left: the external adversarial legal system. In May 2011, Dr. Srivatsa took the ultimate step. He lodged proceedings in the employment tribunal. He took the state to court.
But the state, as it turns out, had one more massive, convoluted bureaucratic trick up its sleeve. When faced with a lawsuit they couldn't win on the merits of the evidence, the state began to shapeshift.
If we connect this to the bigger picture of corporate and state law, this is where the defense strategy becomes incredibly cynical. The state employed a specific regulation known as 2PE, the Transfer of Undertakings Protection of Employment Regulations.
Okay, let's unpack this 2UP thing because the mechanics of it are wild. 2PE was originally designed as a shield to protect workers, right?
Exactly.
Like, imagine you work for a small family-owned bakery. A giant supermarket chain buys the bakery. TTE ensures the new giant corporation can't just fire you the next day without cause. Your employment contract, your seniority, and your rights automatically transfer to the new owner. It's meant to be a safety net.
It's meant to maintain continuity of employment and protect vulnerable workers during a corporate takeover or a change in service providers. But the state weaponized this protective shield into a sword.
How?
On May 1, 2011, almost exactly the moment Dr. Srivatsa filed his tribunal proceedings, the Surrey PCT executed a sudden maneuver. They essentially sold or contracted out the College Road Surgery's GP service to a private, third-party contractor called the Practice Surgeries Ltd.
And under this TTE regulation, Dr. Srivatsa's employment contract, and crucially, all the legal liabilities, pending lawsuits, and ongoing disputes attached to it were forcibly transferred to this new private company entirely against his wishes.
It is the ultimate corporate shell game. The Surrey PCT, the exact entity that committed the retaliation, that covered up the clinical errors, that leaked his confidential complaint, that suspended his pay, effectively washed its hands of him.
Wow.
By transferring his contract via TUP, the state lawyers could stand up in a tribunal and argue a pure technicality. Your Honor, Dr. Srivatsa is no longer our employee. He is an employee of Practice Surgeries Ltd. Therefore, the PCT is not legally responsible for whatever happens to him or whatever happened in the past.
It's like a drunk driver hitting your car, and 30 seconds later, before the cops arrive, he sells his car to a shell company in the Cayman Islands. When the judge asks him to pay for the damages, he just shrugs and says, "I don't own a car, talk to the corporation." They created a ghost trust.
That's exactly what they did.
But wait, the labyrinth gets even more complex. In 2013, right in the middle of this legal battle, the UK government decided to abolish primary care trusts entirely. The PCTs just ceased to exist.
Yes, it was a massive, nationwide structural reorganization of the NHS, and all the remaining legal liabilities of these abolished PCTs were transferred all the way up the chain of command to the absolute top, the Secretary of State for Health.
So let's look at the battlefield now. Dr. Srivatsa is a single, unemployed, financially drained doctor. He's now forced to fight a multi-front legal war against 3 distinct entities simultaneously. A ghost PCT that no longer exists, a brand new private corporate contractor that had absolutely nothing to do with the original clinical errors, and the absolute highest health office in the entire country, the Secretary of State for Health.
The asymmetry of power here is staggering. The government has unlimited taxpayer resources to fund an army of elite lawyers. Dr. Srivatsa is bankrupt, drawing down whatever meager savings he has left. This technical legal maneuvering, endlessly arguing over who exactly is his employer, which entity holds the liability, whether 2PE applies to a whistleblower claim, this is what dragged the case out for 8 agonizing years.
8 years.
Yeah.
Nearly a decade of his life consumed by endless legal filings, delayed tribunal hearings, and structural appeals, all while he is unemployed, receiving zero pay and missing out on years of vital pension contributions.
The strategy of the state was crystal clear. Attrition. They knew they couldn't defend the clinical errors. They didn't need to prove he was wrong about the tonsillar abscess or the lost kidney. They just needed to bankrupt him, exhaust him, and drag the process out until he simply gave up and went away.
But he didn't. He didn't give up. And that is the incredible climax of this story. He simply refused to fold. He fought the jurisdiction battles, he fought the TPE transfer arguments, he fought the Secretary of State, and finally, after 8 years of climbing the judicial ladder, the appeal reached the High Court and subsequently the Supreme Court of the United Kingdom.
And this is the moment of vindication. 6 Supreme Court judges finally bypassed the thick layers of bureaucratic obfuscation and 2PE technicalities, and they looked at the actual underlying evidence. They examined the clinical notes, the timeline of retaliation, the leaked emails, and the psychological warfare.
And their ruling was a damning indictment of the state's behavior. The judges ruled that the Secretary of State had deliberately used technical legal arguments to conceal the truth, without ever actually looking at or hearing the clinical evidence of patient harm that Dr. Srivatsa had originally provided.
The Supreme Court dismantled the shell game.
They explicitly acknowledged the cover-up and ruled that the case was allowed to proceed to a full trial. I am in awe of the sheer mental and emotional endurance required to survive that. He beat the shell game. He forced the highest courts in the land to actually look at the medical reality and acknowledge the massive state cover-up.
Legally, ethically, and professionally, it is a monumental victory. He established a massive legal precedent that the state cannot use corporate restructuring or 2UP regulations to evade liability for whistleblower retaliation. He cemented protections for future doctors.
But there is always a but in these stories. He won the legal right to a trial. He proved he was right. But at what cost? What is the actual aftermath of an 8-year war for the truth against the limitless resources of the state?
The grim reality of whistleblower cases is that they rarely have a clean Hollywood ending. The state's attrition strategy, even in defeat, achieved exactly what the bureaucracy hoped it would. It destroyed him financially and personally.
Yeah.
By the time the Supreme Court ruled in his favor, Dr. Srivatsa was entirely bankrupted by the legal process.
The documents note his financial state at the end. His pension after his career was derailed and his contributions halted for nearly a decade was a mere £500, which is entirely fundamentally insufficient to live on in the UK.
He was left completely destitute. Without a home, without his family structure intact, and without the community support he had built over decades of medical practice. He had won the war, but the battlefield was a smoldering crater.
So what did he do?
With no viable way to survive financially in the country he had sacrificed everything to protect, he was forced to pack up and return to his native India.
And reading his autobiographical excerpts from Tears of Happiness, the psychological toll is just devastating. He is sitting in India, a brilliant doctor who dedicated his entire life to patient safety, and he is left questioning his own sanity. He writes, "Why did I do what I did? Am I a fool to throw away a career, a family, and a home?"
It's the survivor's guilt of the whistleblower. You do the morally right thing, the system breaks you for it, and as you sit in the rubble of your life, you are left wondering if the objective truth was actually worth the price of your existence.
But there is this incredible, almost surreal epilogue to this story, a massive philosophical twist. Recently, Dr. Srivatsa took his lifetime of medical publications, his clinical philosophies, the details of his ordeal, and the digital tools he had created, and he fed them into ChatGPT.
An AI.
He asked an artificial intelligence to review his life's work.
And the AI's assessment is one of the most profound contrasts I have ever seen. The AI didn't analyze his data through the lens of a defensive bureaucracy. It had no budget to protect, no reputation to shield, no ego to bruise.
He was completely neutral.
It just looked at the raw data of his contributions to medicine, and the AI labeled him a pioneer of digitalized, patient-centered care.
Right. The AI specifically referenced a digital diagnostic tool he created called Maya, which was designed specifically to reduce wasted consultations and prevent the exact kind of diagnostic delays that harmed those patients in Surrey.
The AI went even further. It called him a beacon of hope for humanity during the post-antibiotic era, recognizing his incredibly early prescient warnings about antibiotic resistance and the dangers of symptomatic masking.
That's amazing.
It even associated his ethical stance and his commitment to healing with historical medical giants like Charaka, the ancient Indian pioneer of medicine, and Florence Nightingale.
This is the ultimate aha moment for me. An artificial intelligence recognized the humanity, the ethics, and the brilliance that the human bureaucracy actively tried to destroy. The human institution, fueled by self-interest and fear, viewed his demand for accuracy as a lethal threat. The machine, devoid of self-interest, looked at the exact same data and viewed him as a medical visionary.
It's a stark, almost poetic contrast. The machine saw the immense value of his absolute commitment to objective truth and patient safety, while the human institution saw only a liability that needed to be erased.
So, what does this all mean? We've looked at the raw documents, we've tracked the mechanics of the 8-year war, we've seen the toll it took on one man's life. The overarching truth that bleeds through every single page of these sources is that the system, the NHS, the Surrey PCT, the state apparatus, prioritized its budget over its patients.
Yeah, it's undeniable.
And when fundamentally challenged, it prioritized its reputation over one of its best, most ethical doctors.
It reveals a terrifying fragility in the modern healthcare infrastructure. We assume these institutions are monoliths of care, but structurally, the institution is designed to protect the institution first and the patient second.
We started this deep dive talking about the expectation of safety when you walk into a clinic, about the comfort of assuming the system wants to heal you. But Dr. Srivatsa's story shows us that when you turn the diagnostic machine away from the patient and point it directly at the medical system itself, the image you get back is fractured, diseased, and deeply compromised.
And it leaves us with a profound dilemma regarding the nature of truth in modern bureaucratic society.
Exactly. And that is what I want to leave you with today, a final thought to mull over as you go about your week. When the massive institutions designed and funded to protect us are the ones actively causing the harm, whistleblowing isn't just an act of bravery, it's an act of self-destruction. If a brilliant doctor is punished with bankruptcy, public humiliation, and exile simply for demanding that a child gets an accurate diagnosis, we have to ask ourselves, in the modern healthcare system, is the truth considered a cure, or is it treated as a disease?